Good afternoon and welcome back to NACFC. I'm Mike Narkowitz. I'm a professor of pediatrics at the University of Colorado and Children's Hospital Colorado, and I'm one of the co-chairs for this workshop. We're going to start with this. Zach will introduce himself and give a brief intro. And then we have 5 speakers. This workshop is a little different than all the other workshops in that we, both Zach and I, also co-chair the new cystic fibrosis liver disease guidelines that are being developed. And we have interspersed 2/3 of the guidelines work into this work. And we've chosen abstracts to kind of highlight areas around these recommendations. He'll talk a little bit more about that. Just a little bit of housekeeping. On the app, if you select the session, there is a Q&A down at the bottom, and you can submit questions throughout this with it. I've already learned that when you open the Q&A, it actually opens to discussion. So at the top, if you touch questions, then we'll see the questions. We don't see the discussion that's going on. The format is 15-minute talk and 8 minutes for questions after each one. So we're going to have questions after each presentation. So if you have, please use the app. We'll certainly take people yelling out, but it will help if you can do that. So with that, I'm going to turn it over to Zach.
Thanks, Mike. I'm Zach Sellers. I'm an assistant professor of pediatrics at Stanford in pediatric GI. And as Mike said, I'm co-chairing this session here on updates on liver disease. We're really excited about this workshop and think it will be real stimulating. I have a few introduction slides that I think will help us as we go through the various talks that we have today. So here are our learning objectives for today's workshop. First, we're going to evaluate the recommendations for screening for liver involvement and disease and cystic fibrosis. We're going to discuss the impact of liver disease and cystic fibrosis and recommendations for monitoring individuals with CF-associated liver involvement and disease. And we're going to explore genetic factors that may contribute to advanced liver disease and cystic fibrosis. By no means do I think we're going to answer all of everyone's questions that we have in this area, but hopefully we'll spur some more questions and continued discussion. Here's a list of the speakers that we have today. I'm not going to read through all these because we're going to introduce them. But as Mike said, we have 2 speakers on some of our guidelines, and then also 3 speakers from abstracts that were presented that we felt that worked well with these. I just briefly wanted to talk about defining CF liver disease, and I want you to keep in your mind as we go through these talks. I think oftentimes we use the term CF liver disease as what I call an umbrella term, and that's because we may be referring to any one of these many things that can occur within the liver. And as you listen to the talks today, I want you to pay attention to what definitions we're using these. I noted here that with the exception of the 2 guidelines talks that use the same definitions for advanced CF liver disease and CF hepatobiliary involvement, all of the other talks use some other variation. And so I think as we look at data as it comes out discussing quote unquote CF liver disease, I think we need to be very mindful of what definitions are being used and how we interpret the data in that sense. A couple of notes about our new hepatobiliary screening, monitoring, and treatment guidelines. We had a large multidisciplinary CF care team members that contributed to this. You'll see their names up throughout the talks, but this consisted of hepatologists, gastroenterologists, pulmonologists, pharmacists, nurse, dietitian, individual with CF, and parent of a child with CF. So we really tried to get different perspectives into this. We were well represented globally with expertise from the USA, UK, Netherlands, Canada, Italy, and France. And we had 3 work groups, one on screening and diagnosis, one on monitoring, and one on treatment. And today we're going to hear from those that were involved in screening and diagnosis and monitoring. We will not discuss treatment recommendations today. Little spoiler alert, I'm sure everyone's interested and wants to know what is the potential effect of CFTR modulators on liver health. However, there is very little data that is yet available, and we were very restricted as to how we could assess this. And so that will not be discussed today. I look forward to continued discussions on that with people. We did an extensive literature review, many papers, many hours reviewing papers, and determined when there was sufficient data to make a recommendation and when there wasn't. And we had an a priori threshold of 80% agreement amongst everyone to advance a recommendation. And the draft recommendations have been sent out for public comment, and we've collated those responses and we're making revisions. Here's a list of all the authors on that. And like I said, each one of the subgroups today that will be speaking will discuss their involvement, who was involved in those. So with that, I think we should dive right into our session. Please welcome everyone in and have a seat. We still have plenty of seats, and I know people will continue to come in, I think, as they make their way here.
For those in the back, there are a fair number of seats up front. I know you don't like the front, but...
Okay, so our first speaker, we're going to hear from Dr. Senthil Sankaraman, who is going to speak on CF-related liver disease is associated with an increased risk of mortality and a higher disease burden in pediatric patients. He comes to us from the Division of Pediatric Gastroenterology in Rainbow Babies and Children's Hospital and is an associate professor at Case Western Reserve University. Senthil?
Good afternoon, everyone. I'm Senthil Sankaraman. I'm a pediatric gastroenterologist at Rainbow Babies Children and an associate professor of pediatrics at Case Western Reserve University. And I thank the organizers for this wonderful opportunity. I think, Zach, you made my work a little bit easier by starting the session. So before that, I have no disclosures. And so as Zach alluded, the prevalence of CF liver disease, it's a wide variation reported in studies, anywhere between 2% to up to 30%. And if you just take hepatic involvement, including hepatic steatosis or elevated liver enzymes, is even higher. So going to the latest CF Foundation registry, which is 2020, it's documented that 2% of all patients, entire patients, both pediatric and adult, have cirrhosis, and 3.5% have CFLD, which is mentioned as non-cirrhotic, and another 1.6% as other hepatic disorders. And then what we know from prior studies is CF-related liver disease accounts for the third leading cause of mortality, coming after end-stage lung disease and then transplant-related problems. And in the latest registry, this accounted for 3.2%. And we did a similar study a few years back using a different database called the HCUP database, where we cannot individualize the patient, but we can see the hospitalizations. And based on that, we noted that in 2003, CF liver disease accounted for roughly 3% of the entire CF hospitalizations, which increased to 7% in 2014. The major take is, I think this increase is likely due to improved diagnostic coding by clinicians, which means increased awareness, and also to some extent of patients living longer with CFLD. But however, we could not see, based on that database, the huge limitation is it accounts for hospitalizations rather than actual number of patients. So we wanted to do a population level data to see what is the impact of CF liver disease on mortality and other disease pattern in people with CF. So this is our aim, to evaluate the mortality and disease burden associated with CFLD in pediatric CF patients using a national level database. So for this, so it's a retrospective design. We got the IRB approval. We used a database called FIS. So this stands for Pediatric Health Information System. This is administered by Children's Hospital Association, which includes approximately 50 hospitals, which are either tertiary or quaternary level hospitals in the US. And we included all the patients less than 21 years of age with CF. And for the diagnostic codes, we use the ICD, the International Classification of Diseases diagnostic codes. So before moving, as we just saw, the CF liver disease has been defined in multiple ways. Thanks to the latest guidelines, in the future we may have like more kind of like universal definition, and that will make the interpretation of studies more meaningful. So we tried to kind of like define CFLD based on, for this study, based on both the North American as well as the European definition. But there are some drawbacks in the database. For example, we don't have ICD codes for all the listed the problems here. For a simple example is fibrosis. We need to quantify whether the patients have advanced fibrosis or early fibrosis. There's no way to find out in a database study. And then also the database we use here, we cannot time it like how longer the liver enzymes were persistently high or not. So kind of like there are some limitations in defining. So to overcome that, so what we did was we wanted to capture the advanced CF liver disease as defined by the latest guidelines. So we included these variables which all have ICD codes. So cirrhosis, liver fibrosis, chronic liver disease, esophageal or gastric varices, ascites, portal hypertension, liver transplant, as well as hypersplenism using the ICD codes. And we intentionally did not include steatosis and elevated liver enzymes. And then this diagnostic criteria has been used by us before as well as by our colleagues. And so we divided into two groups. People with CF who fulfilled any of the above listed diagnoses are classified as a CFLD group. And then we compared that without this liver involvement as control groups. We compared demographics and comorbid conditions, and we took mortality as our primary outcome. So we got a total of 21,827 CF patients between 2004 and 2021, that is 17 years. And in this population, using this definition, the prevalence was 6.4%. And comparing the demographics, you could see that patients with liver disease are a little bit older, preponderantly male, and then also with Hispanic ethnicity, and also had public insurance. And then there was no difference between the household income between the cohorts. And then we did analyze all the comorbid factors, and I have included only the significant one. Patients with CFLD in that cohort, you could see that a lot of severe comorbidities, such as respiratory failure, mechanical ventilation, ICU admission, pulmonary hypertension, lung transplant status, diabetes mellitus, which is a surrogate of CFRD, malnutrition, need for parenteral nutrition, as well as malignancy are higher compared to CF patients without liver disease. And then specifically for the mortality, mortality is about 4 times higher in the liver disease group in this univariate analysis. So then we kind of moved on to multivariate regression. So when we talk about the mortality, the CFLD could be confounded by the presence of other variables. So we ran a multivariate regression to see how much CFLD has the effect on. And we still retain the significance, and here is 1.72 times higher in the CFLD group compared to the control group, which was significant, and the confidence interval is 95% confidence interval here. So coming to the limitations, one is a retrospective methodology, and then using diagnostic codes, as I alluded earlier, sometimes we don't have the ICD codes for all the conditions or all the disorders we intend to do. And then, of course, the main important thing is coding errors. If the clinicians are not aware or clinicians are not coding, which means that it definitely reports in under-reporting. And then also, as we all know, as liver clinicians or CF clinicians, the pertinent clinical details are not included, which includes what are the liver function tests, what are the CF genotypes, what is the sweat chloride, and then the imaging details, liver biopsy findings, and then also the treatment details. So we couldn't include those. And the main reason for a CF clinician focusing liver is to find these patients at the early stage. We intentionally did not include because of the design of the study. And then also, this is only to pediatrics, and we did not include adults. So those are the significant limitations. So despite that, our study has a lot of strengths, including a very large sample size, closer to 22,000 patients. And then inclusion of multiple centers definitely helps us to overcome single center or single institution bias. And then also we employ the multivariate regression, which is another statistical tool to overcome some of the confounding factors. So to conclude, here in our study, the prevalence of CFLD was 6.4%. And CFLD cohort was associated with increased mortality, about 1.7 times higher compared to the controls, and also associated with various multiple comorbidities, just representing a sick cohort or a cohort with more significant disease burden. And prospective multi-center longitudinal studies will help us to further delineate how much liver disease per se has effect on mortality as well as the disease burden. And this is our study team. And I would like to thank my Digest mentors, my institution supporters, and then also my collaborators for this wonderful opportunity. Thank you, and I'll take any questions.
Thank you, Senthil. If you have questions, you are more than welcome to use the app. I don't have any questions put forward on the app. We'll get to a couple in a minute. And then there are a couple of seats on this side and a couple of seats on that side. One question came up? Okay.
Yeah. No, we have two. Okay, so I'll ask the first question from Leah Hughes. It says, what does that 6.7% compare to the past 5 years? So do you have a longitude?
That's a very good question. So the way how this database works, it's a little bit challenging. Unlike our prior database where it is just hospitalization annually, which was a little bit easier to tease out. Whereas here, we intentionally did not do to avoid duplication of the same patient. So in this first database, every patient is given a unique code, and then depending upon the number of hospitalizations, it's still the patient is retained as one patient. So it gets a little bit harder with this database to kind of see a temporal trend. But what we can do is we can do, like right now we have a lot of newer, we are in a very significant time frame. The introduction of modulators, the upcoming new guidelines. So we can compare the study with in the future to see how much the diagnostic codes or number of patients go up and how the impact is. So it can be done in a little bit different way, but unfortunately we didn't do it.
Thank you, Senthil. The questions are rolling in now. So do you have any information on the cause of death? It's from Frank Burrows.
That's another question, another good question that we did not. We have to the other thing with the database, unlike a single center or like a more clinical retrospective study is, we have to be cognizant of number of variables we select. The more variables we select, it gets harder to run the multivariate regression. But that's a very important question. So again, I want to for your clinicians who are not familiar with big data or these databases, how I see that database is it helps us to identify the problem, or like if you kind of the analog will be to find where the smoke comes from in a big jungle, and then we can kind of zoom in then the kind of like how to kind of address that issue. So it just basically gives an overall idea that this cohort is has a lot of significant comorbidities. And then the mortality could be from any reason, not necessarily from the liver, which kind of that's another big disadvantage.
Thank you. Jennifer Gell asks, what is the average age of death of the patients?
That's a good question. I think we did not pay attention for that for this abstract, but then for our manuscript, we are going to kind of like look for that. Yeah, that's doable. We can do that. Yeah.
Okay. And Dre Gelly had asked a similar question as Frank about cause of mortality and whether this was related to liver or pulmonary issues. I think you answered that.
Right. Yeah, as I said, it could be either way. Yeah.
Senthil, these data actually are pretty similar to data that came out of Europe, suggesting there's an increased all-cause mortality in individuals with advanced liver disease. I don't think any of us really understand the mechanism of that, but is there anything in your data that might get at that?
So, this transpired is some of our late teen or older in the sense less than 21, 22 years patients with liver disease, when they get admitted in the hospital for, say, for example, pulmonary exacerbation, I kind of pretty much see a phenotype, like they're more malnourished, even though they have a compensated liver disease, the time taken for them to recover from that hospitalization seems longer. And so I kind of, I feel like it's often underestimated, like going back to the registry data, which mentions 3.2% mortality from CF liver disease. That's direct association or the direct reason, whereas I feel like the top two causes, end-stage liver disease as well as transplant-related patients, I feel like even in the first two groups, which causes more mortality in CF patients, the liver may play a significant role. In other words, I think it's a axis with chronic liver disease, malnutrition, more inflammatory status, getting patients frequently sick. That's something in your prospective trial which needs to tease out. As unfortunately, we don't have a way to early diagnose CFLDR. We are just coming up with the newer tools to find the early involvement of CF liver disease. And unfortunately, we still don't have a proper good therapy to halt the process. We don't know the consequences of what the modulators will do. So all those questions are still kind of unanswered. So it's nice to kind of see how much liver has effect on other comorbidities and also mortality.
And one last question from Sarah. I may say the last name wrong, Kubis. 25,000 subjects you referred to, are those unique patients, or are they hospitalizations, or are they actually patient days?
That's a very good question. I was expecting that question. So I was in my mind, just given the number of patients we have in the US, which is closer to 30 or 35,000 patients, that number seemed a little bit higher for me, like 20,000 patients. And then the 50 unique hospitals, there could be, to some extent, there could be some duplicates, like say patient getting a treatment in hospital A could move to hospital B or can go for hospital B for second opinion or for a different service, things like that. So there could be a little bit duplication in that patient. But then we ran we included the patient every year. So if you see that, like the prevalence is the incidence is closer to 1 in 3,500, which means that on an average we have like 1,000 babies in US born every year. So those get added every year, along with the patients who already kind of like existing. So it comes closer to the foundation registry has data with patients less than 18, more than 18, but here we included up to 21. So kind of like 2,000 or 3,000 patients seems like a little bit higher than what we expected, but that's a very good question. And again, as I said, those things are not uncommon, or it's just hard to kind of account those for. But then the patients are unique patients. Thank you.
Okay. Thank you.
Thank you very much.
So our next speaker is David Assis. David is an associate professor of medicine at Yale. and a hepatologist. He's going to talk on screening and diagnosis recommendations from the new guidelines.
Thank you so much. It's a real honor and pleasure to be able to be here today with you all, and thank you so much to Mike and Zach for the kind invitation and for the privilege of being able to work on this document. I have no relevant disclosures. So my task today is to introduce some of the statements and some of the rationale behind the statements that went into the portion of the document that relates to screening and diagnosis. And first and foremost, I'd like to acknowledge and really thank the entire committee, but most specifically for this purpose, the Screening and Diagnosis Committee, Nicole Green, Melissa Bowen, Stacy Allen, Frank Bodas, and Daniel Peckham, myself, who worked so well together, and they really put a lot of effort into this, as well as, of course, Meg Sathe and Shruti Paranjape for the monitoring and treatment, as well as Zach Sellers, Mike Narkowitz, and Sarah Hempstead. Thank you all so much. Let's start by just setting the stage. We know that CFTR is not expressed in the hepatocytes, but it is expressed in the biliary cells, also called cholangiocytes. And while the biliary tree, as we all know, it represents a very small percentage of the mass and biomass of the liver, we know that in cystic fibrosis, there's a variety of injury and injury patterns, which is partly why the definitions can be so heterogeneous. We know that the liver parenchyma can be involved through hepatocellular injuries, such as steatosis, as well as cholestatic injury. We know that the biliary tree can also be affected, be it through strictures, biliary stones, intra and extrahepatic lithiasis, as well as gallbladder disease. And lastly, something that we're becoming more familiarized with over time is the risk of vascular abnormalities, which can lead to nodular regenerative hyperplasia and the non-cirrhotic portal hypertension phenotype. If you put these all together, though, as I think was just demonstrated very eloquently in the last talk, that we know that liver disease is one of the leading causes of death and burden of medical care in persons with CF, and with an increased longevity over time, which is certainly a good thing, we do believe that the burden of CF liver manifestations will significantly increase, not just in pediatric populations, but also in adulthood. Lastly, the guidelines, at least from a U.S. perspective, that were introduced in this topic are from 1999, and needless to say, we're in a different landscape to a large degree compared to where we were more than 20 years ago. A brief word on terminology. This was introduced earlier, but just very briefly for this discussion, and this will be carried forward. So advanced CF liver disease is defined for purposes of this guidance document as having one or more of the following: either a nodular liver, advanced fibrosis, equivalent to stage 4 fibrosis, or multilobular cirrhosis. And this could be with or without portal hypertension, be it cirrhotic or non-cirrhotic portal hypertension. In contrast, the broader term of CF hepatobiliary involvement can be characterized and defined as having one or more of the following, listed here, as you can see, and this really brings up a variety of different manifestations, getting to the heterogeneity of the disease itself. But importantly, for purposes of this document, CF hepatobiliary involvement does not include features of advanced CF liver disease. So we'll start with the first statement then from the group, which is that annual labs should be performed at a time of clinical stability for identification of CF hepatobiliary involvement in all persons with CF starting at the time of diagnosis. And the specific labs that are outlined are shown here: synthetic function markers such as total bilirubin, hepatocellular inflammatory tests such as AST and ALT, markers of biliary inflammation including GGT, and a surrogate for portal hypertension in the form of platelet count. We do know, of course, that elevated enzymes can occur at any age in the context of CF. And we also know that liver test abnormalities can precede imaging abnormalities and correlate with fibrosis. So there's a long-standing tradition of monitoring labs, and we are trying to codify this for purposes of screening. Focus on at time of clinical stability. We all know that the patients with cystic fibrosis have various infections and other hospitalizations and other medical issues that can make a period of stability an important issue to emphasize. There are multiple causes of elevated liver tests, such as a drug-induced injury that might be temporary, reaction to antibiotics, or even a systemic inflammatory response. And the other issue to emphasize is, what do we mean when we say abnormality or normal labs? The prior guidelines had emphasized elevations up to 1.5 to 2 times the upper limit of normal. But for current guidelines, we are characterizing abnormalities as any abnormality above the normal range adjusted for age and sex. And more importantly, that persists. persist for greater than 3 to 6 months. And this, hopefully, at a time of clinical stability, can give the confidence to see that this is a real abnormality. And we do know that CF hepatobiliary involvement is associated with early and persistent elevations. A word on liver fibrosis indices. Many in this group are probably well familiar with this, but these are calculations shown on the graph and on the table that can help to give a sense for the severity and perhaps the more advanced stages of liver disease, in particular portal hypertension. They can detect advanced fibrosis and portal hypertension at more specific levels than individual labs. And in particular, the committee has focused on the AST to platelet ratio index, or APRI, and the GGT to platelet ratio, or GPR. These indices can be calculated, and there are some routine EMR-based methods to do so. And as outlined here and also in the document, there are some emerging thresholds that still need to be further developed. But the optimal thresholds have not been broadly accepted in the context of all persons with CF, and therefore the utility of these indices in patients who do not have known hepatobiliary involvement is currently uncertain. Therefore, we do not currently recommend that all persons with CF have these indices calculated on a routine basis. However, they should be calculated in patients who have the diagnosis of hepatobiliary involvement, and this is something that will come up more specifically in the monitoring discussion to follow. The second statement, I think, is a pretty general one, but it's always worth highlighting, that annual abdominal examinations should be performed to look for hepatosplenomegaly as a way of identifying advanced CF liver disease in all persons with CF starting at diagnosis. The definition of hepatomegaly and splenomegaly is shown here, and I think we all know from a physical exam perspective that there is a lot to learn, particularly in the era of telemedicine, and I think that it is important to reemphasize the need for a physical exam. One of the few studies, though, that has looked at this in a more robust way, correlating physical exam with biopsies in persons with CF, showed, as listed there, a sensitivity and specificity for hepatomegaly of 60% and 44% respectively for advanced CF liver disease, and for splenomegaly, sensitivity and specificity of 93% and 57%. And while one might say that this is somewhat imprecise, I think it's reasonable to assume that not only because of low cost as a non-invasive method that can be easily repeatable, there is high value in performing this at least on an annual basis, and therefore there was not any controversy among the group on that point. Third, the recommendation from the group is that abdominal ultrasound should be performed at least every 2 years to identify CF hepatobiliary involvement in all persons with CF, starting within the first 1 to 2 years after diagnosis. And the goal of this ultrasound, as you can imagine, is to identify liver and spleen abnormalities. We feel that ultrasound is readily available, non-invasive, and with a modest cost. And studies have supported the notion that ultrasound abnormalities often can add information beyond laboratory and physical exams and correlate with those tests. The relevant ultrasound findings are varied, of course, and can include steatosis, parenchymal heterogeneity, surface nodularity, medial lobe hypertrophy, and of course signs of portal hypertension, including ascites, splenomegaly, and mesenteric edema. The PUSH study, of course, which is a research protocol but has prospectively analyzed the role or the utility of ultrasound. One recent study from 2 years ago showed that a heterogeneous liver pattern compared to normal had a 9.1-fold increase in incidence of subsequent nodular pattern on subsequent ultrasounds. And a study that has very recently been accepted and is in press showed that in patients who had a nodular liver pattern, there was a higher risk of varices subsequently over 10 years of up to 20%. And importantly, of that subgroup, 2 patients developed variceal bleeding and 2 underwent liver transplantation, while none of those events occurred in people who had a normal pattern. Now, clearly, there are some studies that have even proposed annual ultrasounds in all persons with CF, but we found insufficient evidence to recommend this on a yearly basis. And it is also acknowledged that the optimal interpretation of ultrasound abnormalities and in the management strategy of CF hepatobiliary involvement needs to be further addressed. However, there was clear consensus among the group, committee members, including patients and patient advocates, that the recommendation should be given for ultrasound because it can lead to early identification of hepatobiliary involvement, and identifying key subgroups will be a way of promoting strategies to address and mediate further damage. The fourth statement is that persons with CF that are found to have CF hepatobiliary involvement should undergo baseline liver elastography to identify advanced CF liver disease. In other words, physical exam, laboratories, and ultrasounds even may not detect more subtle and earlier stages of fibrosis, and we do know in chronic liver diseases that fibrosis assessment is important. A variety of chronic liver diseases, including biliary diseases such as PBC and others, have shown us that distinguishing mild to moderate fibrosis from more advanced fibrosis at baseline can impact the prognosis and the clinical care in patients. The three main modalities for elastography or stiffness include transient elastography, shear wave elastography, and MRI elastography. The cost and burden of MRI-based elastography made it unattractive to the group, and also it has not been very well studied in the context of cystic fibrosis. Therefore, the guidelines are focused mainly on transient elastography and shear wave elastography. And you can see from this graph from a very nice paper from about 3 years ago that there is a nice correlation between liver histology on biopsy and the degree of stiffness as measured in kilopascals in the study of patients with CF. There are some emerging thresholds for these conditions, not only for CF hepatobiliary involvement, but also for advanced CF liver disease, as exemplified here with different degrees of accuracy and area under the receiver operator curve. Certainly, different institutions have different familiarity and different patterns, and it'd probably be best to focus on one or the other for continued longitudinal care. But we do believe that this is important at baseline. The next statement, which is uncontroversial for sure, is that anyone found to have CF hepatobiliary involvement should be carefully assessed for any other causes or additional causes of liver disease. Now, depending on local availability and experience, this can be done in consultation with a gastroenterologist and hepatologist. As we all know, there are a variety of other liver disorders that can occur in persons with CF, in particular alpha-1 antitrypsin, which we all know has a potential modifying effect on the CFTR mutation. As patients live longer, there are a variety of metabolic and even genetic causes that can be modulators and can compound the risk of liver damage in persons with CF, and it's very important to not miss chronic viral infection, autoimmune disease, or genetic abnormality. The last statement then is that in persons with CF who have cholestatic liver test elevation and abdominal pain, but have an inconclusive biliary exam through ultrasound, should receive an MRCP, which is a magnetic resonance cholangiopancreatography. We know and are beginning to realize more the burden of stones and hepatolithiasis, choledocholitis, and biliary strictures. Although it's a subgroup of all persons with CF, it does have its own kinetics, characteristics, and clinical presentation. We found a variety of studies, both in chronic biliary diseases and in cystic fibrosis, showing conclusively that MRCP is superior to standard ultrasound for the assessment of the biliary tree, and therefore it should be routinely performed in somebody who has those clinical signs and presentations. There was one area in which there was insufficient consensus to recommend, to make a recommendation, and I'll just spend a minute on this, which is there was not enough consensus to recommend a liver biopsy in persons with CF who are found to have portal hypertension. I do point out that the level of agreement was close to the 80% threshold, but nonetheless, this was not formal, and I'll explain this. I think as some in this crowd are aware that there is an increasing realization of the potential different patterns that can lead to portal hypertension, whereas liver biopsy was left by the wayside for the most part over the past decade or two. Some recent studies have shown that non-cirrhotic portal hypertension has been recently characterized in a number of post-transplant case series in which patients were transplanted for what was thought to be cirrhosis with portal hypertension, but yet had a different phenotype, specifically obliterative portal venopathy that can cause changes to the liver tissue, but in the context of preserved synthetic function. The cause in cystic fibrosis is not very well understood. It probably has something to do with a combination of intestinal inflammation, perhaps reaction to medications, and even thrombophilia. The test, of course, to distinguish between cirrhotic portal hypertension and non-cirrhotic portal hypertension is a transjugular liver biopsy with measurement indirectly of portal pressures, called HVPG. The rationale for a biopsy can include the need to clearly determine the presence or absence of cirrhosis, which in some cases can help guide therapeutic decisions, such as management of portal hypertension, or in the case of cirrhosis with portal hypertension, moving toward liver transplantation. The rationale against a biopsy is that clearly the thresholds for triggering this biopsy are not quite understood and we are not very well defined. And as I think we can all understand, the potential complications from an invasive procedure, especially in patients with compromised pulmonary function, are not well established. I do think that an individualized discussion between the team and the patient is advisable in these scenarios, and perhaps over time we'll have a better understanding of the thresholds and the value of confirming this when we have this phenotype. So in conclusion, some of the algorithms that we see here summarize what we have in terms of the recommendations for screening and diagnosis. All persons with CF should have annual laboratories checked. They should have an annual physical exam, specifically targeting the liver and the spleen, and an abdominal ultrasound is recommended every 2 years to, again, comment on the liver size and appearance and the spleen size. If there is evidence of hepatobiliary involvement, the next question is, what is the baseline level of fibrosis, which can be done non-invasively using transient elastography or shear wave elastography. Alongside that, there should be a very thorough evaluation for additional or concurrent causes of chronic liver disease. And then for a specific subgroup that might have cholelithiasis or other biliary abnormalities, if there is obstruction, risk of cholangitis or subsequent symptoms, an MRCP should be obtained. Lastly, and this will transition to the next discussion and monitoring, depending on the degree of fibrosis, whether we're dealing with hepatobiliary involvement or advanced CF liver disease, the management will vary based on that. And with that, I will be happy to take questions. Thank you.
Thank you, David. The audience has clearly figured out how to do questions, so that's great. We're going to hold on a couple of the questions because they actually relate more to monitoring. So remember, this is really about diagnosis, and once diagnosed, it goes to monitoring. So we're going to hold on one or two. But a couple of questions. One, Drusy Borowitz wants to know, and you may not know the answer, whether clinically obtained ultrasounds or elastography data will be entered into the patient registry.
Good question. I do not know. But I do believe that the clinical care guidelines here are to assist with clinical care, and there's a separation between that and automatically assuming these will be part of the database requirements.
Right. But the first step to adding items like that are really guidelines that suggest the data that it should be determined. So we'll wait and see. My sense is elastography values would be what we would enter, and clinical radiologic interpretation may be more difficult. And the other one that I have from Kimberly Treichman, to my knowledge, there are no known normal elastography values in pediatrics. Is there work being done on this, or do we think there is likely to be significant difference between adult and pediatrics?
Well, that's a very good question. I think the non-invasive thresholds have been studied to a degree, although there's some variation in terms of the optimal threshold, but very clearly in persons with CF who do not have hepatobiliary involvement, there is a separation with lower transient elastography and shear wave values. The definition of normal clearly would need to be validated for each disease, but I think the available studies do give us the opportunity to have some thresholds that can be used to distinguish between the two.
And just to further amplify, there is actually one large study in PROMISE, another study I run, and then there's a large liver disease network across the U.S. that are looking at values in children also, and the CF study included normals. Zach?
Okay. I'm going to combine two questions from John Roberts and Andrea Kelly. Is there recommended age to start screening using ultrasound, and is there an upper age limit when you can discontinue every 2 years after they've been normal?
Great questions. This was debated extensively among the group. I think there is some emerging data that the early findings of abnormalities can be important over time, and in the absence of clear data as to when among the lifespan we should be looking for abnormalities, it was a clear consensus of the group that within 1 to 2 years after diagnosis, this should commence. Again, I think the underlying premise for everything that was done in this screening and diagnosis committee is that we should not hopefully be finding in 10 or 15 years late-stage disease. We should be categorizing and understanding this at early enough stages that we can have interventions and hopefully some therapeutics. As to when to stop looking at that also is an important consideration. I'm an adult hepatologist, and very clearly we have a large burden of liver disease, of course, in the population, but also in cystic fibrosis. And I think the kinetics of that in the adult population needs to be further studied. I think that adhering at this stage to every 2 years into adulthood is sensible, and clearly over time this will be further refined. Thank you.
Thanks. John Hines asks, any evidence that every other year ultrasound will significantly decrease overall morbidity or mortality?
That's a good question. I think the data that was recently presented earlier today, as well as the known consequences of having an advanced presentation, probably do make a case for when we would like to understand whether somebody has advanced disease versus mild disease. That has not been demonstrated yet, but I think in the context of cystic fibrosis and the promise that, or hope that there will be some effective therapies targeting hepatobiliary involvement, it is very reasonable to identify populations at risk. I think the way of intervening will help determine this as well, but very clearly we hope to have targeted interventions and targeted monitoring and management. And so I think the first step really is to understand what we're dealing with.
So, whoa, sorry. Couple of more questions. One from Benjamin San. For clinicians who have point-of-care FibroScan by experienced hepatologists available in the office, do you have an opinion if that can be done in place of sending the patient to radiology for ultrasound?
Very good question. At least in my institution, we have a FibroScan or transient elastography in the clinic, but it is also available through radiology. And I think we very clearly understand that there's very much heterogeneity around the country and around the world as to what is available and what the local patterns are. It is not difficult these days, at least for radiology, to incorporate elastography into ultrasound in addition to shear wave. And so I think the local patterns are reasonable to follow and to have a method and to stick with it.
Yeah, so just to clarify that is if you have an experienced hepatologist, someone that can do FibroScan in the office, and that is suitable as well. We wanted to provide people with options, and so you can use either modality. But I think, as David pointed out earlier, I think it's important. We all think it's important to use the same modalities time after time as much as you can, so you can have longitudinal changes in that, because the different modalities can give you some different results.
So I'm going to take this one. How can we access, Nathan Minkoff asked, how can we access guidelines, and if not available, when and where will they be published? Good questions. The guidelines still are under finalization. They were out for public comment. That public comment has ended. We are in the process of revising the document. It will be submitted for, then it goes, I'm asking my guidelines expert over here, Sarah. Then it goes to the foundation. Yeah, and so I think within the next, my hope is within the next 3 to 4 months, we'll have it submitted, and hopefully it will be quickly accepted, but I don't control that. We have time for one more. Quick, 1 minute one. All right, then I'll take this one. Do you think cutoffs or trends are really what we are looking for? This is from Jay Freeman. How do we address intra, so the variability in the person, and inter, variability among the community, person variability?
Yeah, it's a great question. I think in all chronic liver diseases, there's a lot of heterogeneity between individuals, even simple things. If we're talking about elastography, whether somebody's fasting, whether they had a recent infection, recent inflammation, liver enzymes can also account for that. So I think period of clinical stability is always important. Between individuals, also, there is heterogeneity. I think the utility, if we're just limiting this question to non-invasive measurements of fibrosis, we're really looking for extremes. If you have minimal fibrosis assessment versus very significant fibrosis assessment, that is probably meaningful. And some of the individual cut-ups in the middle, I think, will be further refined as we can validate what's currently out there.
Yeah, and I would just add, because we didn't say it earlier, David mentioned that there's been a couple of decades since our last guidelines, and our hope really is that it won't be that long till the next version, right? So all of these questions that we're bringing up, I think are going to be very poignant, and as we, the guidelines we're putting forward aren't meant to generate data from a research perspective. They were for clinical care guidelines, but certainly as we reevaluate our experiences, we'll be able to refine these recommendations.
Yeah, so hold those thoughts. Thank you.
Thanks.
Okay, that's my pleasure to introduce the next speaker. We have Daniel Tewksbury, who's currently a clinical fellow at Manchester Adult CF Centre in the UK at the University of Manchester. And he's going to speak with us about his work on changes in liver function tests and liver stiffness measurements over 12 months in CF patients commenced on elexacaftor, tezacaftor, ivacaftor at a large adult center.
Thank you very much for attempting the full title. And thanks very much to the organisers for the invitation to speak here today. It's a pleasure to be presenting work undertaken at Manchester Adult CF Centre in the UK regarding changes in the liver over the first 12 months of therapy with elexacaftor, tezacaftor, ivacaftor or ETI. I have no disclosures. So the context is the licensing and widespread clinical use of ETI, which has led to substantial benefits in pulmonary status for a majority of people with CF. However, questions remain about the effects of ETI in other organ systems, especially the liver, as raised transaminases were noted in clinical trials with some discontinuations. And apologies, I think that should actually be 2 discontinuations if we include the F-gating clinical trials. As well as that, there have been case reports of hepatic necrosis secondary to ETI. And the effects of ETI in those with CF liver disease are still relatively unknown, especially as some were excluded from clinical trials on this basis. And this can present both clinicians and patients with some difficult decisions when encountering liver abnormalities after starting ETI, and also for patients with established liver disease. Our aims were therefore to try and determine the effects of ETI on the liver in the first 12 months of therapy, and also to determine whether this experience is any different for those with a diagnosis of CF liver disease. And we did this in 2 main ways. Firstly, we looked at changes in liver blood tests, which were performed every 3 months for the first year of ETI therapy as part of routine clinical monitoring for all patients started on ETI in our cohort at Manchester Adult CF Centre. We excluded people who stopped or interrupted treatment within the first 12 months for reasons not related to liver abnormalities, and also people who transferred their care to other units. Diagnosis of CF liver disease was made according to clinical or Debray criteria, but as we've been hearing, the diagnosis of CF liver disease is a clinically heterogeneous and broad term. So we also looked at people with more advanced disease, and by this we meant people with cirrhosis and or portal hypertension. And in addition to that, we also wanted to look at people with an alkaline phosphatase, which was greater than the upper limit of normal at baseline, in order to try and get some indication of the effects of ETI in people with a more cholestatic phenotype, as we know that CFTR is expressed in cholangiocytes, as we've heard. The other way we evaluated changes in the liver was by use of elastography or FibroScan. And we had a cohort of patients who had previous measurements of liver elastography prior to starting ETI therapy. And so for these patients, we repeated FibroScan a year after they started ETI. And again, we looked at these changes in people with liver disease as well as cirrhosis or portal hypertension. But as even in people with advanced CF liver disease, this can give a predominant clinical phenotype more of portal hypertension with relatively well-preserved liver and synthetic function. So we wanted to look at people with a FibroScan at baseline, which is indicative of fibrosis, and we used a cutoff of 6.8 kilopascals. So of 269 patients on ETI, we had 255 who completed therapy for 12 months with no discontinuations related to liver abnormalities. Most discontinuations were in fact related to pregnancy. In our cohort, 30% had a diagnosis of CF liver disease, and 10% had cirrhosis and or portal hypertension. So this graph shows median values for individual liver tests at the different time points measured. And the two middle lines show ALT and AST. And what that showed was a numerically small but statistically significant rise in median values from baseline to 3 months, all remaining within the normal range. And those levels stayed stable but relatively unchanged over the remaining time periods. And there was no significant change in median values for ALP at the top or gamma GT at the bottom over the 12-month period. We also observed a small decrease in median albumin over the time period for reasons we're unable to really fully explain, and also a numerically small but statistically significant rise in median bilirubin, again from baseline to 3 months, which remained stable thereafter. When looking at people with CF liver disease and the change in individual liver tests over 12 months, there was no difference for those with CF liver disease compared to those without CF liver disease. And this was also true for people with portal hypertension and/or cirrhosis. However, for those who did have a raised alkaline phosphatase at baseline, there was actually a significant reduction in ALP over 12 months compared to those with a normal alk phos at baseline. In the 60 individuals where we repeated liver stiffness, there was no change in liver stiffness from baseline to follow-up, despite a similar mild rise in transaminases observed in the rest of the cohort. In terms of difference over 12 months, there was no difference between people with CF liver disease versus no liver disease, and this was also true of people with cirrhosis and/or portal hypertension. However, when we did look at those people who had a raised baseline FibroScan using the 6.8 cutoff, there was actually a significant reduction in liver stiffness over 12 months compared to those with the normal baseline value. In terms of people who developed clinically significant rises in transaminases, and for this we defined as greater than 3 times the upper limit of normal, there was 8 individuals who developed an ALT of greater than 3 times the upper limit of normal, 3.1%, and 6 of these individuals also had a significant AST rise. And in fact, when we looked in further detail, in all but 2 of these cases, this could be explained by alternative causes such as alcohol, alternate medications, viral infection, or weight resistance training. And in the remaining 2 cases where there was no other explanation found, neither had a pre-existing diagnosis of CF liver disease. Both of those individuals went on to have liver biopsy. The first case had a significant abnormality detected 3 months after starting ETI. This remained stable, but due to persistence at 18 months, they went on to have a liver biopsy, which was in fact normal, and she continued on ETI throughout. The second case first had a significant abnormality developed at 12 months, and due to rapid increase, ETI was paused for 4 months to allow liver function to normalize before being subsequently reintroduced. And a liver biopsy following this showed mild periportal inflammation, and that individual has managed to remain on ETI. And actually, since then, we've had a couple more individuals who've had liver biopsies due to unexplained raising transaminases. One showed significant steatosis, and the other showed hepatic necrosis, and they've had to discontinue ETI. Although it's worth noting in that individual there was no pre-existing hepatobiliary involvement or liver disease prior to that happening, suggestive that this may be more of an idiosyncratic drug event. In terms of limitations, this was an observational single-center cohort design in an adult population. There are only small numbers observed with clinically significant rises in transaminases, so difficult to draw conclusions. And as has been mentioned in the previous talks, there's a lot of heterogeneity in the term CF liver disease, which is why we looked at various subgroups in our analysis. So to conclude, LFT abnormalities after starting ETI can comprise mild rises in transaminases or bilirubin with changes sustained for 12 months. There were no difference in these changes for people with CF liver disease and no greater incidence of significant abnormalities. Therefore, we think CF liver disease should not be a barrier to treatment with ETI. A reduction in ALP may actually indicate improved CFTR and function in cholangiocytes, although it's difficult to be certain. And a reduction in liver stiffness for some may indicate that ETI is even potentially therapeutic where liver fibrosis is present. Thank you very much.
Thanks, Daniel. While I'm waiting for questions to come in, I have one question. I'm struck by the increased alkaline phosphatase that improved, but so it's a two-part question where there's also parallel abnormalities in GGT that might have not shown up in your mean with those. And if not, is it possible that that alk phos is actually related to improvement in intestinal function versus liver?
Yes, so we didn't observe a corresponding increase in gamma GT. It was alkaline phosphatase, and definitely it's not a specific, marker for cholestasis. So it's definitely possible that it could be due to improvements in other parameters.
One question. What percentage of your patients in your group were on prior CFTR modulators?
I can't remember the numbers offhand. I think there's a small percentage who are on ivacaftor due to licensing in the UK. Yeah, someone says Ivan.
Yeah. One question submitted by Eric Walter says, should recommendation to check LFTs every 3 months after starting ETI be lifted, given your findings?
Yeah, very interesting, very interesting question. Obviously, our findings are just, in a generalized large population, and when we did, our findings do suggest that abnormalities occur from 3 months onwards, and you could make an argument, is there a need to do them every 3 months thereafter? However, I think what we did observe is that for people who did get those significant LFT abnormalities, some happened at 3 months, some happened at 12 months, and again, it was more in keeping with a kind of idiosyncratic reaction with no predictable time frame. So I think it's on the side of caution is probably best.
I'm going to make a comment. First off, I consult in this area, but this is all publicly available data. Based on the post-registration studies, which include now over 20,000 individuals who've been there, there are episodes of significant abnormalities in liver blood tests that occur even outside of this time frame. So wanted to study volume. The second comment I'm going to make is that although you talked about CF liver disease not prohibiting ETI therapy, there is a black box warning for individuals with significant advanced liver disease and ETI therapy. It doesn't say you shouldn't do it, but it should be cautiously considered. There are 2 case reports now of transplant in individuals with unsuspected advanced liver disease due to drug-induced liver injury. So just a little caution on your but I think globally, by your definition of CF liver disease, you are correct in that one.
We have another question from Jason Rocha. Were these patients exposed to ursodiol during the study?
I think about 30% or a bit more were also on a similar proportion to those with a diagnosis of CF liver disease, but not identical populations.
And similar findings, I assume, between the 2 groups.
Yeah.
And there are a couple of questions. One from Nathan Minkoff again, and this is really around clinical management, where there are adjustments in the Trikafta dose in this study if there were increases in liver enzymes. And
So with adjusted dose.
so in those, were your doses adjusted if individuals had elevations of liver enzymes?
No, we didn't adjust dose for people with significant abnormalities. I think As I said, we have one case where we suspended treatment due to significant abnormality rather than dose adjust, and then the ETI was later reintroduced, but not based on any kind of data or anything. We chose to reintroduce it in a gradual fashion, so starting with ivacaftor, then Tez-Iva, then Lex-Tez-Iva.
And one more question. This is actually a really nice question from Angela Delacaris. Most of the individuals in your study really look like they were reported, at least their means, were totally normal ALT and AST for most of the patients at baseline. So what is your pattern of starting ETI if a patient has CFLD with higher AST or ALT before starting it? Before starting ETI. Another way to ask this question is what percentage of your patients actually had abnormal AST or ALT as they entered into this study to help people interpret this?
So, we did look at this, and I think only a minority of patients had kind of elevated transaminases at baseline. And again, it was a similar sort of pattern, but just with higher baseline numbers, so they increased slightly, but remained stable afterwards. So I guess as long as you're doing routine monitoring, we found it safe to continue.
So I guess the follow-up question is, there were not adjustments in the way you started ETI in those individuals? They underwent the same protocol?
Yeah, no adjustments.
With that, we'll move on to the next. Thanks, Tim. Yep, it's my turn. Trying to manage the questions and all of this at the same time. All right. It's my great pleasure to introduce Meghana Sathe, who is the co-director. She's a gastroenterologist, co-director of the Cystic Fibrosis Center, and she's professor of pediatrics in the Division of GI and Nutrition at UT Southwest and Dallas Children's, and she's going to talk about monitoring. Meg.
All right, well, here are my disclosures. Okay, so I'm going to discuss monitoring. So this is after you have screened and diagnosed either cystic fibrosis with hepatobiliary manifestations, or you have a patient with advanced CF liver disease. And before I begin, I would like to take a moment to recognize the members of the monitoring subcommittee for their work, especially because for all of you who are not aware, we did all of these guidelines during COVID. So we never met in person. This was all done virtually over the course of 2 to 2.5 years. Okay, so the CF Foundation recommends that in persons with CF and liver involvement, a liver-specific physical exam be performed at least annually and at each in-person visit to monitor progression of disease. So what we're looking for is changes in size, shape, contour of the liver, and spleen that can be signs of advancing liver disease. Typically, initially, the liver is enlarged, and with progression of advanced liver disease, usually the liver shrinks and the spleen actually enlarges. The organs can become more firm to touch in end-stage liver disease. You can sometimes even appreciate nodules. Ascites, prominent abdominal vasculature, signs of neurologic changes indicate advancing liver disease. Nowadays, with the use of telehealth growing since COVID, it's really important to state and emphasize the need for a physical exam when the opportunity presents itself. We do often find that we are not seeing our patients in clinic on a regular basis anymore. The CF Foundation recommends that in persons with CF and hepatobiliary involvement, at least one liver fibrosis index be calculated annually. So liver fibrosis indices have been utilized regularly in other liver diseases to monitor progression of disease. And many of these, including the ones that David had mentioned, and I have up here, APRI, FIB4, Forns Index, and GPR, have been studied in the detection of CF, hepatobiliary involvement, and progression to advanced CF liver disease. So all of these liver indices have been noted to have a high sensitivity and low specificity for liver fibrosis, with elevations correlating with nodular appearance on ultrasound, presence of portal hypertension, varices, and advancing fibrosis. As there is variation in comfort, you need to pick the one that you're most comfortable with. And the labs that are required to calculate these fibrosis indices are all part of the CF labs. And as David indicated, you know, a lot of us use EMR these days, and so you can actually program into your EMR the calculation, and you can follow annually the changes in these fibrosis indices, and you can even have normative values, which will help you in a busy CF clinic. Mike, it's stuck on the... Okay. So as David also indicated, so we're going to be doing ultrasounds every 2 years from 1 to 2 years after diagnosis of CF, and we'll continue to do ultrasounds every 2 years when you diagnose CF hepatobiliary involvement. Abdominal ultrasound is non-invasive, it's safe, it's low-risk way to monitor disease in persons with CF identified to have hepatobiliary involvement. It can detect new or evolving heterogeneity of the liver parenchyma, nodularity, hepatosplenomegaly, reversal of portal venous, reversal and flow of the portal venous system, and ascites. While the literature is not clear whether annually or less often should be appropriate, the recommendation was made thinking about a balance of obtaining this important study as well as the burden of having cystic fibrosis and everything else that is required year to year. Of note, though, I'd like to remind you that persons with CF, including those with liver disease and their loved ones, were part of the guidelines, and they did participate in evaluating the literature and in voting in these guidelines. So in terms of annual evaluation for liver stiffness, again, we recommend that in patients with both CF, hepatobiliary involvement, and advanced CF liver disease, that this is calculated at least annually. So multiple studies have shown that both transient elastography and shear wave elastography can be used to diagnose CF hepatobiliary involvement and to follow progression. The best results have been shown, as Zach mentioned, serial measurements over time. So pick your favorite one or the one that's most consistently available to you and follow that over time. While newer MRI technology has shown to provide promising and rich information, transient elastography and shear wave elastography modalities are more available and more cost-effective. It is recommended, again, to follow the same technology with time. There are mild variations in values in the results of TE and shear wave elastography that correlate with cystic fibrosis, hepatobiliary involvement, and advanced liver disease. Again, here we put, as well as in the fibrosis indices, hepatitis B as a comparison. This is a very common form of liver disease in the general population, and so does provide some comparison for us when we're thinking about our patients with cystic fibrosis. Okay. The CF Foundation recommends that persons with CF and hepatobiliary involvement or advanced liver disease receive consultation with a pharmacist with experience in CF and hepatobiliary disease to identify high-risk medications, polypharmacy, therapy modifications, and risks based on hepatobiliary disease every 6 months to improve morbidity and mortality. So polypharmacy is very common in patients with CF. We use lots of antibiotics, modulators, psychiatric medications, herbals, and over-the-counter supplements, which often our patients do not tell us about. So many of these medications and supplements are metabolized through the liver, including our CFTR modulators, as has been noted already. And multiple studies have shown that both inpatient and outpatient pharmacy consults improve treatment of infections, decrease length of hospitalizations, decrease medication error, and overall improve safety for our patients. Given the higher risk of drug-drug interactions leading to drug-induced liver injury on top of cystic fibrosis, hepatobiliary involvement, or advanced liver disease, it's really imperative to have our patients have the opportunity to speak with a pharmacist at least every 6 months. So now we're going to move to advanced CF liver disease. So the CF Foundation recommends that in persons with CF and advanced liver disease undergoing a liver-specific examination and measurements of AST, ALT, GGT, and conjugated or direct bilirubin, albumin platelets, and international normalized ratio at least every 6 months to detect the progression of liver disease. So here I'm really going to emphasize the labs. You can often see rising ALT and AST, which indicate hepatocellular injury. However, I will say in end-stage liver disease, often these numbers are normal. Elevation in GGT is more specific to the biliary tree where CFTR is located and has a direct impact. So there is a lot of literature, as you wouldn't be surprised of, really looking at elevation in GGT being an important indicator in progression from cystic fibrosis, hepatobiliary involvement to advanced liver disease. Significant elevations in conjugated bilirubin or direct bilirubin occur when there's profound injury, hepatocellular injury, and these are usually seen in the end stage. We do see lots of mild elevations of indirect hyperbilirubinemia that have been seen with the use of ETI. Important indicators of liver function are albumin and INR. Albumin can sometimes be difficult to interpret because it is an acute phase reactant and can sometimes be decreased when you have significant inflammation. In terms of platelets, whether they're low or even if you see decreasing normal values, this can be an early indication of developing portal hypertension and often is also accompanied by an increase in your spleen size. So the CF Foundation recommends that persons with CF and advanced liver disease receive a nutritional assessment for malnutrition and liver-specific macro and micronutrient deficiencies every 6 months by a dietitian experienced in CF. When abnormalities are identified, a treatment plan should be made and nutritional rehabilitation should be monitored even closer than every 6 months. So we do know that with both CF and then having advanced liver disease on top, you are increased risk for malnutrition, and especially poor weight gain and growth, as well as fat-soluble vitamin deficiencies. In addition, there does seem to be an increased incidence of glucose intolerance and CF-related diabetes in patients with advanced CF liver disease. Given these complexities, it is important for patients to be seen at least twice a year versus annually, which is now recommended for all patients with CF. The CF Foundation recommends that for persons with CF and advanced liver disease, we begin CF-related diabetes screening at diagnosis of advanced liver disease, even if this is earlier than 10 years of age, and then annually thereafter unless they're diagnosed with CF-related diabetes. And while there are no studies really looking at OGTT in the setting of advanced CF liver disease, it is known that the liver plays an integral role in glucose metabolism. Not surprisingly, there are multiple studies that do show the incidence of increased CFRD in patients with advanced CF liver disease as compared to those without liver disease. So one study did find in a cohort of 88 patients with children with CF with baseline heterogeneity or cirrhosis on ultrasound, there was an increased incidence of CF-related diabetes. A case control cohort study from Australia found the odds ratio of 2.6 for CFRD in those with advanced CF liver disease compared with no liver disease at all, or even hepatobiliary involvement. And ALT elevation and insulin resistance was identified in a cross-sectional study of 273 CF adults screened for CFRD. So again, it's really important to screen, especially those patients under 10 years of age that we wouldn't routinely think about, to screen them with an OGTT if they have been diagnosed with advanced CF liver disease. The CF Foundation recommends that in persons with CF and advanced liver disease receive multidisciplinary care from pulmonology, gastroenterology, hepatology, endocrinology, and when appropriate, a transplant center to optimize liver outcomes. And while there is a lack of literature specific to CF in this area, there is literature in transplant that recommends multidisciplinary care. The recent 2019 CFF lung transplant guidelines also emphasized the importance of communication between the primary CF center and transplant to assure that patients received optimal care. And multidisciplinary care should not just include subspecialty providers, but other parts of the team, which are really important, including your dietitians, psychologists, physical therapists, social workers, and pharmacists. So what about advanced CF liver disease with varices? So this was a little bit of one where we were challenged with the recommendations, but we decided that it's best to follow the guidelines by other organizations that look at this a little bit more broadly in terms of advanced liver disease. So the adult recommendations are to follow the AASLD or Bovino guidelines. A large retrospective study of the CF registry showed that between 2003 and 2012, there was an incidence of 3.6% of patients to have cirrhosis. And of those, the 10-year cumulative risk for variceal bleeding was 6.6%, with the mean age of the first bleed around 18.8 years. Again, this all has to do with coding, and as noted in a previous presentation, we are probably underreporting CF liver disease in the registry. So in a different study, CF patients with variceal bleeding were 5 times more likely to undergo liver transplantation, but all-cause mortality was not impacted by variceal bleeding. So screening for varices is performed by upper endoscopy under anesthesia, which allows for identification and characterization of the varices, and then therapeutic intervention. The Bovino consensus recommendations really focus on the treatment of portal hypertension in adults. And so in patients with compensated cirrhosis, the recommendation is to wait to screen if the platelet count is greater than or equal to 150,000 and liver stiffness is measured by transient elastography as less than or equal to 20 kilopascals. If these thresholds are crossed, then it is recommended to go ahead and do a surveillance endoscopy and then go ahead and do surveillance at least every 1 to 2 years. Now, for those pediatricians in the room, unfortunately, we still don't have any recommendations for you guys. There's nothing in the literature to tell us what to do. In terms of cirrhosis and the risk of hepatocellular carcinoma, so in terms of recommendations for adults, again, to follow AASLD or EASLD guidelines, and for pediatrics, again, not clear recommendations, but to follow our adult recommendations. While the incidence of hepatocellular carcinoma in CF and cirrhosis is unknown, there are multiple case reports in the literature indicating that it does exist. And we know that there is an increased incidence of GI cancers in our patients with CF as they're getting older. And so we suspect with increased survival, there's going to be increased risk of hepatocellular carcinoma with ongoing liver disease. So the recommendation right now is that if you know your patient has cirrhosis, for adults to undergo ultrasound at least twice annually looking for a mass, and annually for children with a yearly serum concentration measurement of AFP for all. And that's the last recommendation I have to share.
Thank you, Meg. As you can see, there's a lot behind these and a lot of debate about the data that was there, because a lot of this doesn't have tremendous data. So I have a question from Christina Chadwick. In persons with CF and advanced cystic fibrosis liver disease who are on parenteral nutrition, are there any specific interventions or alterations in monitoring that should be considered?
So they should see the dietitian much more frequently and really be monitored for all those things that we monitor for when our patients are on parenteral nutrition, including some of the elements that are in parenteral nutrition, like copper and things like that. Should be you should use biliary trace elements and really watch for increased drug-induced injury from your parenteral nutrition. So they should probably be monitored at least, every 2 to 3 months, if not more frequently, with the help of your dietitian.
And then a question from Nathan Minkoff. Just could you re-clarify again who should get alpha-fetoprotein testing?
So David and I were actually talking about this a little bit more. I think we use alpha-fetoprotein as a marker of hepatocellular carcinoma a little bit more in pediatrics than in adults, where my understanding is it is a little bit more controversial. So ultrasound twice a year for adults, and then for pediatrics, ultrasound once a year, AFP once a year, and then in adults, it kind of depends on if you feel like that's a helpful marker or not.
But again, Meg, can you clarify, actually, obviously not everyone with CF liver disease should get it, but those with?
Advanced CF liver disease, not those with CF liver disease and hepatobiliary involvement, and not just advanced liver disease with evidence of cirrhosis. So the cirrhosis is really the key for who you are monitoring for hepatocellular carcinoma.
I expected many more questions on this one. Your group must have done a fabulous job of searching the literature. Oh, yes.
I just want to clarify that you were talking that one before on guidelines, the ultrasound, is the recommendation to perform a first ultrasound only at the detection of any sort of liver abnormality, or just in general with the diagnosis?
Yeah, so I'll take that one. So the recommendation for screening for liver disease is that ultrasound be performed roughly every 2 years, about 1 to 2 years after diagnosis. So those are all comers. And continued, at the moment, the recommendation as it's drafted, which has not been finalized, and I don't want people to take this home and say, this is gonna be the guidelines, because there was extensive public comment, which we really appreciate, and we're meeting later tonight to go over all the public comments. So these are the draft recommendations that were put out. They are not the final recommendations, and there may be some modifications. There may not, but there may be. So, you
Go
want
ahead.
me? Yeah. Yes, I know. So we can talk after, and I can answer that. But I want to be clear, what we've not talked about is treatment. So individuals, for example, with advanced liver disease who have variceal bleedings, where the recommendations are in treatment, those will come out with that. So stay tuned. When you start compounding, these guidelines are generally made to develop kind of approaches to sort of the standard problems where there are data. I will tell you there are no data for the complex compound problems you're asking for. And there was a question in the back. It is, and I'm not going to steal the thunder of, it's in these guidelines, but they're broken into screening, monitoring, and therapy, and we're not talking about therapy today with it. But it will be addressed in the guidelines.
Yeah, to the last question, I think I would just highlight something that Meg mentioned is really, I think, the importance of having many different players in these discussions, right? I think that as the problems become more complex, having more minds, our pulmonologists, gastroenterologists, hepatologists, even sometimes multiple hepatologists, gastroenterologists weighing in is important. And recognize that can't be done at every center. But this is where we can rely on each other and reach out and really put more minds together to help these patients where there really is no data, just our experiences to help guide those.
Yeah, and I think the biggest thing in advanced CF liver disease is the comorbidities start adding up. And so really these patients just need to be seen more frequently, monitored more frequently with all the players on the team so that we can optimize care.
I'm just looking through. We've learned on this app that when you open it, the first thing that comes up is discussion, so we have to look at the discussion and the questions. Just for later, if you tap on questions, it'll go there. So I think this is the question I was going to hold for this. This is from John Heinz. Is there any evidence that every other year ultrasound, particularly after the diagnosis of liver disease, so in the CF hepatobiliary involvement, will significantly decrease overall morbidity or mortality? David took it, but I'm going to let you take it too.
Yeah, so I don't think that there's evidence that it will decrease morbidity and mortality. I think it will give us a lot of information, again, about evolving liver disease and make us look for those comorbidities. So if you start seeing evidence that you are progressing from CF hepatobiliary involvement to advanced liver disease, then I think, there is good evidence out there that there's glucose impairment, and that could be contributing to why your patient is not growing well, why their nutritional status isn't great. And while we don't have great treatments yet for CF liver disease on how to halt it, these other comorbidities are important to take into consideration. In addition, a lot of times our patients get a lot of organomegaly as they develop advanced CF liver disease. We've had patients who've had, we work with the pulmonologist to increase their pulmonary clearance. They might be at increased risk for infections because they just have so much, their lung capacity decreases. So I think it's more important to do the ultrasounds to really detect subtle changes that would then maybe guide you, especially in a patient less than 10, to do an OGTT early, get the dietitian involved early, really look at their polypharmacy, all these other things that can contribute to as much minimizing the progression as you can. Or getting them to a transplant center if you need more help and opinion, getting them to a gastroenterologist and hepatologist to be involved in care too.
All right, thank you very much.
Thank you.
We're I'm going to just point out to the audience that Zach's going to announce the speaker who is not on the list because that speaker is sick. So we're going to give this speaker, although he is well known to this group, a little bit of leeway because he's doing someone else's slides, which I've also done in my time. But the good news is if you really like the presentation, it's all him. And if you don't, it's the part of the person who is supposed to present it.
So as Mike mentioned, we have a pinch hitter today for Dr. Jacqueline Stonebreaker, who probably needs no introduction, but Dr. Mike Knowles is going to speak on her behalf. He's a professor of medicine at the University of North Carolina, and he's going to talk on their work on discovery of novel genetic variants in severe cystic fibrosis liver disease as determined by whole genome sequencing.
Jackie Stonebreaker sends her regrets for not being able to be here and give this talk. And nothing like being an adult pulmonary doctor speaking to a group of experts on liver disease. Our liver disease specialist actually in this project is Simon Ling from Toronto Children's Hospital. And unfortunately, Simon can't be here today either because he's at a competing liver meeting of some sort. But the bottom line, we're shifting gears enormously, going to talking about discovery of novel genetic variants that may alter a risk for severity of CF liver disease as determined by whole genome sequencing and statistical analysis. There's going to be very little on molecular and an analytical methodology here today. We're really just going to talk about the big picture. As Jackie has, I have no relationships that are conflicting for this meeting. Before we get started, I want to call attention to Peter Dury. Peter was a wonderful friend and colleague that we worked with on gene modifiers for many years, passed in 2018. But when I started working in modifier gene studies 20 years ago, Peter was our liver and GI expert, and he was the one that insisted that we study patients who had well-defined liver disease associated with portal hypertension so that we really knew they had liver disease. Now, of course, then we didn't know that you could have, venopathy as a cause of portal hypertension, but we know that now. We want to recognize Peter for all of his contributions. This is going to be brief, obviously, for this group. Liver disease is one of the leading causes of death in CF. Many patients have abnormal liver function tests, but Simon tells me that I can say as many as 5 to 7% may have portal hypertension. We know that there's one genetic variant in the alpha antiprotease gene, the Z allele, known to be a risk allele for developing severe liver disease with portal hypertension. And the reason we're able to do this study today is the CF Foundation sponsored a genome project where they performed whole genome sequencing actually in 5,000 people, but that included 516 people with severe liver disease and 3,500 people without CF validated to have liver disease, hoping to identify additional modifier variants for severe CFLD. As we talk about this today, I'm going to make some speculative comments as we have looked at the data perhaps in a different way over the last few weeks. And so hang with me. It's going to be interesting to see what you have to say about some of the comments that I make. This project, the CF Genome Project, comprised of 5 cohorts, and obviously this study was designed to study a host of phenotypes, lung disease, CF-related diabetes, CF liver disease, et cetera, with patients being enrolled from Johns Hopkins, University of North Carolina at Chapel Hill, and the University of Seattle Children's Hospital, obviously with one of those from Chapel Hill being the severe CF liver disease study. And as I said, 5,200 samples were whole genome sequenced. That generates an enormous amount of data, but fortunately we were able to have high-quality statistical people helping us to analyze these data. I do want to call attention to several things. We defined CF liver disease patients that were recruited worldwide in over 100 sites with severe liver disease defined by imaging showing abnormal liver parenchyma. Emphasize that does not say that you can say whether this is cirrhotic portal hypertension or non-cirrhotic portal hypertension. Obviously, we wanted them to have a definitive, objective evidence of portal hypertension, including esophageal varices, et cetera, and these primary data were all reviewed by 2 expert hepatologists, Simon Ling and Peter Dury, before his death. And, of course, there was no explanation for the liver disease outside of CF. The patients that we studied who were controls without liver disease were actually recruited from North America based on these other studies we've talked about. A couple of interesting points to make from the nature of the patients enrolled. There were more males than females, as you might predict from the traditional information that's available. The mean and median age of the CF liver disease diagnosis in our cohort was around 10 years of age. And for those people who did not have CF liver disease, we did a diagnosis by age analysis, and they were censored if the last time we had data, and that was their age 24 years. Obviously, most of these patients had homozygous delta F. Most were white, as you would predict. About 90% of the patients with liver disease were enrolled from North America or Europe, whereas all of the controls were enrolled from the U.S. I'm going to give you 3 scenarios here. Phase 1, we're just going to look at the SERPIN-A1 genetic variant for the Z allele, which was retested as a candidate gene. And then we'll go on to two other things which I will tell you about. What we found was the same thing we had found before. About 5.6% of the 515 patients with CFLD, severe CFLD, carried the Z allele, whereas only 3.4% in the control population. And it's actually interesting that we still got a significant value despite the fact that 3.4% is higher than population studies would suggest. So our prediction is that there are some occult liver disease patients in our control group that we just couldn't find. So that is continues to be true. The second thing, we were thinking of liver parenchyma. So we thought, well, we'll be smart. We'll go to the literature. We'll find these genetic polymorphisms that have been associated with different types of liver disease, and we'll do a candidate gene study, candidate gene because there's so few liver disease patients for this kind of study. And maybe we'll learn something about this before we do a whole genome sequence and GWAS analysis. And we were surprised to find that of 174 SNPs in which we could say the direction of effect, that is, which variant was increased risk, none of those 6 categories of liver disease showed up anything, nor if you looked at all the SNPs together. Now that said something to us. First, we said, well, CF liver disease must have a unique pathophysiology. And then later on, we said, well, wait a minute, CF liver disease, portal hypertension, maybe this has to do with, this obliterative portal venopathy. And we'll come back to that several times during this talk. The final thing, which is the most interesting because we have some novel data here, is looking at a genome-wide association study ascertained from the whole genome sequencing, and we looked at SNPs that had a minor allele frequency of at least 1%. This is a so-called Manhattan plot. Remember that the log to the -10 p-value is on the y-axis. The x-axis shows the chromosome that the SNPs are on, and highlighted in red are 2 genes that were genome-wide significant with only 500 patients, which is pretty astonishing. We were never able to predict that. And they got 2 genes in blue, which were highly suggestive. They didn't quite meet genome significance, but those 2 are there. What I'm going to do now is to show you locus zoom plots. That is to show you the region around these different genes and then discuss these different genes explicitly. So on the left side, the first significant variant was found in PKD1, which codes for polycystin 1, and with a p-value of 10 to the -10. Interestingly enough, the minor allele frequency was only 1.9%. So that tells you this genetic variant must have a large effect size for you to get a whole genome significant p-value there. This is actually a coding region SNP in PKD1. But interestingly enough, this sort of makes sense. PKD1 sort of makes sense because it causes polycystic kidney disease. It causes cysts in the liver. It's expressed by hepatocytes, and it's also known to be associated with a congenital hepatic fibrosis. Okay, so this is a liver parenchymal genetic variant, but I'm going to point out that we actually looked up. It actually turns out that PKD1 is expressed in endothelial cells and is associated with endothelial cell migration. And we'll come back to this as the story unfolds. The gene on the right side is FMBP1. That's a formin-binding protein that has to do with, it gave us a p-value of 10 to the minus, 7 times 10 to the -8. And again, it was a low minor allele frequency gene, 1.7%. So again, it must have a large effect size to show up here with that kind of p-value. This formin-binding protein relates to modulation of actin polymerization and microtubule stability. If you actually look to try to figure out, there may be low-level expression in the liver, but there may not be much expression in the liver. And we started looking further, and now we know that it plays a role in endothelial barrier integrity. So we come back to that vasculature stuff. For the two suggestive genes, genes with suggestive p-values, we have these two. DUSP6 had a p-value of 1.5 times 10 to the minus 7, a minor allele frequency that was 20%. So that is not, so that's a pretty common genetic variant. And this gene is called dual specificity phosphatase. And interestingly enough, we know that it does several things, but we also now know that it has a role in the regulation of endothelial inflammation and NFKB signaling, which relates to inflammatory pathways. So again, we have an interesting candidate. This is an intronic variant, and it'll bear watching. The other suggestive SNP was in ANKUB1, which is a polycystin repeat and ubiquitination domain with a p-value of 4 times 10 to the minus 7, and again, a relatively low minor allele frequency, 4.7% for the risk allele. So again, it must have a fairly strong effect size. This gene has a very low level of gene expression in almost all tissues except for lung cilia, which are motile cilia, and testes. And the sperm tail has the same components, genetic components, that make up a cilia for motile function. It also has a role in immune, but again, we think this is expressed in endothelial cells and has a secondary indirect role in inflammation, and it plays a role in cilia assembly and organization. So we're seeing things that aren't obviously related to liver parenchymal disease, and we're trying to think about other ways in which they might be related to portal hypertension. Then we also did one other thing. You can actually take these single nucleotide polymorphism variants, and you can go to public databases, and you can see the relation between gene expression by the genetic variant versus the more common allele, and look at differential expression, and lo and behold, 3 genes came up as genome-wide significant. And again, that is very surprising because of the small number of patients. I'm going to get rid of talking about TRBV24 because there's almost nothing known about that. Maybe it has something to do with an immunoglobulin or whatever. But focus on CXR1, which is a chemokine receptor, and AAMP, which is an angio-associated migratory cell. The CXCR1 is expressed in liver, and guess what? It regulates endothelial cell migration as well. The other AAMP involves IL-8, involves cytoskeleton reorganization and is associated with changes in avascular permeability. So we keep coming up with these things that don't so directly relate to parenchymal liver disease. And so as we sort of look back at these, you can think about PKD1. Of course, it is associated with cholangiocyte, calcium homeostasis, et cetera. But remember that it also is associated with endothelial cell migration. FNBP1 is associated with cytoskeleton, as I talked about, in intracellular signaling, but that also is associated with vascular barrier integrity. The suggestive gene, DUSP6, is associated with cell differentiation, proliferation, and survival, but again, it's associated with endothelial inflammation. The ANKUB is probably associated with cilia assembly, but again, expressed by endothelial cells. And the transcriptome-wide association study also had those variants in CXCR1, which has a role in immune function, and AAMP, but both of these genes are related to an endothelial cell migration or vascular permeability. So I think conclusions are that we confirm the Z allele probably does play a role in the development of cirrhosis, parenchymal liver disease, and portal hypertension. Interestingly enough, we found no association with the published SNPs for 6 different categories of recognized liver disease, suggesting that CFLD has a unique pathophysiology, and could that actually be related to portal venopathy? And this is going to require a lot of study. So we hope that we have tweaked the hepatologists and gastroenterologists' interests into thinking about these genes and the obliterative portal venopathy that I'm hearing about now. It's like an explosion of information, and since I don't do that business all the time, it's quite gratifying to look at these data and say, maybe there's something there, but we're going to need your help in digging in and thinking about this. I just want to point out, to enroll and get primary source data on these 516 patients, there were over 100 sites, and I'm sure many of you in this room submitted enrolled patients into this study, which is terrific, and you can see that maybe we've learned something that's important. And of course, we owe a debt of gratitude to the CF Foundation for sponsoring the CF Genome Project. And you're going to be seeing papers on genetic variants that associate with risk for lung disease, CF-related diabetes, meconium ileus, BMI, and et cetera. And this paper on CF liver disease is also going to be coming out, we hope, soon. So thank you.
So, Mike and Jackie, in her absence, a tremendous tour de force in this work and a really valuable resource. There is a question from Frank Bodis, and you may or may not know the answer. Were the significant SNPs independent of one another, or were they clustered in groups of patients?
That is a great question. Let me stop and think just a second. I can't answer that. That's a great, who asked that question? That's a great question.
Frank Bodis asked
Good.
that question.
We'll find that out.
You can come work in his lab. All right. Thank you very much, Mike. I have one closing slide for the group, or two. So we've done all the questions and answers. I just want to highlight, this is not the only work that's been done on liver disease. There are many posters. I just highlighted 6 here. I'll give you a minute if you want to take a picture, so you can go see those posters. This is a hot area of involvement. And then I just wanted to summarize with, what did we learn? One takeaway for each one. So I think we learned that if you have advanced liver disease and you happen to be in a children's hospital registry, that your outcome is worse, and it's really all-cause mortality that's there. So those individuals need really special attention. From David, we learned about the guidelines that kept many of the things that were there before, but really new features around fibrosis indices, elastography, and imaging that if these are finalized in the guidelines, you'll use. From Dr. Daniel Tewksbury, we found that at least in their cohort, there were not really very significant changes in liver with ETI therapy. Meg talked to us about the new guidelines for monitoring, and Andy Kelly's going to like that I highlighted, a really high prevalence of CF liver disease, of CF-related diabetes, and starting early to screen individuals with advanced liver disease. I will comment that there is some tie between the all-cause mortality in advanced CF liver disease and probably CF-related diabetes. We know there's increased all-cause mortality with CF-related diabetes. You put those two together, it's probably not a very good thing. And then from Jackie through Mike, we learned about these novel SNPs, and I did this before they did their reanalysis, and he's telling us it's all about the endothelium. So with that, please enjoy the opening reception and go buy all the posters.